Welcome back. I hope you're all enjoying Eyecelerator. I think this has been the best Eyecelerator yet. It's the first one, actually. Welcome back. One of the great unmet needs in ophthalmology right now is dry eye. It's estimated that there are 30 to 40 million patients a year in dry eye, and there's so much innovation taking place in dry eye. And today, Eyecelerator celebrates all these new companies that are coming into this space right now, and I can't think of a better person to moderate this session, the person who probably knows more about dry eye than anyone I know, and that's Ed Holland. Ed Holland, come on in and let's start the session on dry eye.
Over here.
There you go.
Thank you. We'll bring out our panel here. Bob Dempsey, Marjan, Farid, Nicole, Fram, and Francis Ma. And since we're on a really tight schedule here, we're going to go right to the talks. It's going to be similar to what we had before, short talks and then a panel discussion. Our first talk is from Vicken Karageozian from Allegro.
First off, I wanted to say to the panel and all the organizers, thank you very much for inviting us to present today. We appreciate giving everybody an update on what's going on with Allegro these days. Thank you. So again, I'm Vicken Karageozian, the president and CEO of Allegro Ophthalmics. Allegro is focused on a portfolio of oxidative stress stabilizers for both front of the eye and back of the eye diseases, and we wanted to take this opportunity to update everybody on both, with obviously an emphasis on dry eye. So our oxidative stress stabilizers give you multiple functions, but one of the important things they do is they give you an anti-inflammatory effect and an ability to stop oxidative stress. We have two late-stage programs right now. One is a pivotal-ready program in dry macular degeneration, and another is a pivotal-ready program in dry eye disease. Both of these are ready to start their pivotal programs in the first half of next year. We have a very experienced ophthalmology team at Allegro. Most of the team comes from prior Alcon or Allergan experience. Bill Link is the chairman of the company, and right now we're in a position where we are looking for our next round of financing for these two pivotal studies, one in dry eye and one in dry AMD. Focusing briefly on the retina side of things before we focus most of our attention on dry eye. For dry AMD, we have an intravitreal injection that again gives you an antioxidative stress effect, and what it does in dry AMD is something that hasn't been thought possible for a long time, which is to reverse vision loss in moderate dry AMD. We finished a phase 2 study already in the US on this, and we've already gotten clearance to do our first pivotal study in the US. For dry eye disease, which is the focus of this panel, we also have a topical eye drop that comes from the same portfolio of compounds. You get a robust anti-inflammatory effect, and we've already finished our first phase 2 study, which we're going to present a little teaser of today, and the full data set will be presented for the first time at this meeting on Saturday. This program is also pivotal ready because it met its primary endpoints strongly, as you'll see. On dry eye disease, so again, with a compound that blocks oxidative stress and gives you a potent anti-inflammatory effect, this is well suited to treat dry eye disease. We've paired this anti-inflammatory peptide with a hyaluronic acid base, so you get the best of both worlds. You get to turn off the inflammation in dry eye, and you get a nice, robust coating effect of the hyaluronic acid at the same time. This last phase 2 study that we haven't shown the world yet, and we're going to give a teaser of now, was built on a 40-patient open-label study that was presented at ASCRS in San Diego 2 years ago. The follow-on study, which we're going to show here, again, is a 64-patient study. It looks like this. This was 64 patients. It's 14 patients per arm, and you're looking at the combination of the novel peptide that we have with hyaluronic acid, so the combination is one arm. And then each subpart is the different arm. So you have our peptide in combination, our peptide by itself, hyaluronic acid by itself, and vehicle by itself. And you have standard signs and symptoms with moderate dry eye disease. What you see here, and again, I don't want to show the full data set because it'll be presented publicly for the first time on Saturday, is you get a robust effect. You can see in tear breakup time, you get a very strongly statistically significant benefit, and on the symptomatology side, in the VAS scores, you see the same thing. The combination works the best. The subcomponents also work quite well, but the combination is strongly statistically significant with a very clean data set. Dr. Donnefeld is presenting the full data set on Saturday at 1:40 p.m. here at this meeting. I hope you can join it. And then in summary again, we are using oxidative stress stabilizers to go after 2 late-stage programs, a pivotal-ready program in dry macular degeneration and a pivotal-ready program in dry eye disease. Both of these are ready to start in the first half of next year, and we're currently raising financing for both of these. Thank you.
Great, thank you. Bob, first comment?
Well, first of all, great presentation.
Thank you.
I think second of all, from what I saw, hitting signs and symptoms in the same study takes me back to some previous work we did. Maybe walk us through how you were able to do that.
You're right. The issue, and you know this very well, it's very hard to hit both the signs and symptoms in one study. That's why both the Xider studies as well as the Rosacea studies ended up doing typically more than 2 phase 3s, because some of the populations where you get dry eye effects where a drug would work are not the same as where you get the symptomatology effects. The signs and symptoms can be hard to treat with one class of drugs, and sometimes they can be in separate populations. What's interesting about this is I think the combination of having a very robust anti-inflammatory and the hyaluronic acid effect at the same time gives you a little bit of the best of both. I remember when I showed this data to Ed the very first time a while back, and he said, well, you know, how do you get both of these? And then you start teasing it apart and you realize the hyaluronic acid is doing this thing with coating the surface of the eye, and then the anti-inflammatory peptide is doing a really good job on the anti-inflammatory side. And together you get a very robust effect.
Gotcha. So the obvious question is next steps with the agency. Can you walk us through that?
Yes, absolutely. So we've seen that both resotaginib by itself, the peptide by itself is statistically significant, works really well. The combination is even better and works even better. And so the question has been now, we've already submitted an IND and had an end of phase 2 meeting with FDA. They've already given us clearance to move forward in our first pivotal studies. We have a phase 2b/3 planned for the US of about 330 patients that's coming up. It should be in the first half of next year.
Fantastic.
Great, thank you. Thank you for the great presentation. We're going to move on to the next talk. Charles Bosworth from Azura is going to tell us about meibomian gland dysfunction treatment.
Hey, welcome everyone. So Azura is developing a portfolio of compounds for the treatment of meibomian gland dysfunction, blepharitis, and other abnormalities of the lid margin, and we're leveraging the unique properties of keratolytic compounds to do that. So meibomian gland dysfunction is a complex condition, affects the glands in the lower and upper lid, and as many as 115 million patients in the United States could have meibomian gland dysfunction. As many as 86% of patients with signs and symptoms of dry eye disease will have underlying pathophysiology consistent with MGD. Now, there's no approved pharmacotherapies for MGD, but patients can use artificial tears, they could be prescribed anti-inflammatories, but these are for the plus conditions or the added secondary effects of meibomian gland dysfunction. There are no treatments for the actual condition itself. In 2011, the Tear Film and Ocular Surface Society defined hyperkeratinization as one of the primary causes for obstruction in MGD. This could occur at the gland orifice, it can occur deeper within the gland, could even change the consistency of the meibum itself. Now, the meibomian glands are hypoxic by nature, but they can undergo oxidative stress. And when they do, you can get aberrant disulfide bond formation within the proteins. And this can then cause blockage at the gland orifice, it can cause a change in the meibum itself. And what Azura is doing is we're evaluating a new compound, AZR-MD001, as a new drug therapy to target this hyperkeratinization. And it leverages the unique properties of selenium disulfide. Selenium disulfide, it's a known keratolytic, it can break the disulfide bonds. It's keratostatic in that it can slow down keratinocyte proliferation. And it's lipogenic in that it can actually promote lipogenesis within the glands and actually within the skin itself. Our program that we've come through, it's a phase 2 program. The studies were all 3 months in duration. And we looked at some primary signs and symptoms across those studies. The signs were meibomian gland score, meibomian glands yielding liquid secretion. And then we looked at symptomology in terms of total OSDI and eye dryness VOS. Now, the ophthalmic ointment that we're using is applied twice a week at bedtime to the lower eyelid margin. What I'll do now is I'll take you through some of the phase 2 results. The first thing we'll look at is the meibomian gland score. The meibomian gland score is kind of a measure of the quality of the meibum that's secreted. On the left-hand part of the slide, what we have is an LS mean change from baseline. On the other side, a responder criteria in terms of how many people get to normal. And the data clearly show a dose response. If I look at month 1 through month 3, and I look at the control in blue up to the 1% in green, it's clearly giving us an increase in efficacy over the concentration range. The next thing it's doing is it's increasing in efficacy over time. And these are the two known aspects of keratolytics from the dermatology space. They do function as an impact of concentration and time. If we then look at the meibomian glands yielding liquid secretion, so kind of a measurement of how many of the glands in the lower lid are producing meibum, again, we see a replication of the MGS results. Here what we see is again that dose response from month 1 through month 3, and then we also see that gain in efficacy over time again. Now, in terms of the response criteria, we did look at a criteria here about a change of 5, and now what you can see is the two top concentrations, both the 0.5 and the 1%, are giving us a significant difference over control. If we look at OSDI, again, we see a very similar pattern of results, giving us an increase in efficacy over time and a separation on the 0.5 and 1%. We see a similar result in eye dryness. So just showing you that the results are robust against multiple symptoms. So this gets me to the safety and tolerability. So we've seen no serious ocular treatment adverse events. Most of the adverse events are mild to moderate in severity and really center around application site tolerability. So in conclusion, the 0.5 and 1% provides statistical significance over control that's clinically relevant, with more than 50% of the patients improving on signs and symptoms. So based upon this data, we've selected the final dosing and dose regimen for phase 3 and have concluded that doses up to 1% are safe and well tolerated. Thank you.
Thank you, Charles.
Wonderful. Thank you so much. That was an excellent presentation.
Thank you.
I think it's so exciting every time I hear new advances in lid margin disease therapy. I mean, as clinicians, we always see this layer of gunk on the lids that we just want to, always clean off. So, any advance in lid margin disease, we know, dry eye disease, at least 85% of patients have some degree of lid margin disease. And we're seeing a lot of advances. Where do you see this product falling within the landscape of now there's, procedural therapies, there's the issue of blepharitis and Demodex. Where does this fall into the landscape, and are these synergistic?
Yeah, that's actually the right question. When we look at it, we think of it as more of a synergistic platform that could work with existing treatments. There's no reason for people to just stop using things like Blefex or stop using things like LipiFlow. There's an opportunity for this to be synergistic with those technologies. It's also synergistic with anti-inflammatories. So if you think about, last or end-stage MGD, where you start to get the inflammation, the recommendations to use anti-inflammatories, perfect. Knock down the inflammation, maintain them on a keratolytic, and just let them progress through. Yeah.
Charles, I think MGD is a very complex pathophysiology, and I think you're right. We'll need multiple different mechanisms to have an effective overall treatment. So you affect hyperkeratinization. Where does keratin fit in the disease severity? I mean, we know that end-stage disease, we have total keratinization, we have obliterated glands, but is it moderate to severe, or do we see keratinization occurring in the mild patient?
Yeah, so we actually designed the program to initially target early to moderate disease. So it's clearly present early and moderate. We've actually run another proof of concept in contact lens discomfort. We're finding it there as well. So in the early disease, it's definitely present. We've also included patients with severe disease. We're seeing it there as well. So we're seeing an effect across the severity range, but we do primarily focus on the DUES levels 1 to 3, where it's primarily driven by hyperkeratinization and less inflammation.
Great. Well, thank you, Charles. Wonderful presentation. Let's move on to the next presentation by Riad Sherif from Oculis.
Thank you. Ladies and gentlemen, very happy to be here to introduce Oculis and OCS-01, our candidate for dry eye. Oculis is a next-generation topical company. So Oculis' mission is really to come up with a transformative, differentiated topical product for back and front of the eye, addressing a major unmet medical need. It has already a pretty late-stage pipeline, OCS-01 and OCS-02. The highlight of OCS-01 is the very first non-invasive topical product for DME, entering phase 3, actually started already the phase 3 in the US. The second highlight is the very first time, first once daily treatment for ocular surgery, post-cataract. And the last one is with great potential for CME, given the fact that the product works topically, works on retinal edema. OCS-02 is the second asset we have in clinical stage, first topical biologic in dry eye and uveitis, and this will be my focus. Pretty diverse and rich portfolio with late stage and early stage. Let me focus now on OCS-02 in dry eye. OCS-02 is an antibody fragment technology, first and only topical treatment for anti-TNF antibody for inflammation in the eye. It is proven, as you know, a biological target with a dual effect, inflammation and necrosis. It is a lower molecular weight, which allows higher penetration into the tissue, but also higher concentration, which drives potency and efficacy. And it has something which is pretty unique, which is a biomarker, and I will go to the details about this biomarker in the next 2 slides. First, in the last phase 2A result in severe dry eye, the product has shown high efficacy in symptoms with a high responder rate and both statistical significant with an excellent safety, but also it showed a pretty fast onset at day 14. It was already statistical significant. But we did also in the same study, in a pre-specified manner, we explored 8 SNPs, 8 gene variances, which are related to the mechanism of the TNF pathway. And what we identified is actually a SNP which allows us to identify the patient who will hyper-respond to the drug, and we see them in the curve. And actually the good news is we can identify this patient with a very simple test. So next step is to move to phase 2B, to continue to validate the product in all comers, but also to have an arm with biomarker to further understand the value of this biomarker. As you can imagine, it might be able to be the first biomarker to drive personalized medicine in dry eye. In conclusion, OCS-02 is a first-in-class biological eye drop, validated in 3 clinical trials, 2 in dry eye and 1 in uveitis, moving to phase 2B in dry eye. As I said, all comers and biomarker, severe dry eye population, and uveitis moving to steroid-sparing alternative for chronic anterior uveitis. The potential, of course, is pretty big for this product. Thank you.
Thank you. Nicole?
So thank you for that great presentation. This presentation energized me because when you think about dry eye, you think about autoimmune disease. And autoimmune disease, the mainstay has always been just give them a steroid. And then biologics changed that whole field. So now the mainstay of some dry eye treatments was give them a steroid or give them what's commercially available. But this one size fits all is not working. We all have recalcitrant disease. Yep. So these high responders really intrigued my interest. So how do you see this fitting into a regular clinic? How do we screen to find these high responders?
Okay, so actually this test is pretty simple test. Based on the US data, 19.9, so 20% of the population have this biomarker basically. So if we go with the biomarker route, we are targeting 20% of the total population with high response. and guaranteed almost response. What I didn't show here is actually we see in the tear film, we see the mRNA expression going down in the same population. So it's extremely objective. Like you see it in symptoms, you see it in signs. I mean, biological signs.
Right. And then the other thing is that for all those patients where nothing's working, this can enter the market as something that can help. Thank you.
Thank you.
So what was your strategy about starting with severe dry eye? How did you think about that?
I mean, this is a biologic, so it needs to go high-end patient. So this is why. So the patient, I didn't show the trial, but the patient were selected. They went 2 times to artificial tears, and then vehicle, and then only patients who didn't respond were selected into this.
You know, as Nicole said, this may really fit a subset of an unmet need because in our most severe dry eye patients, they often don't tolerate cyclosporine or lifitegrast. And then you also have this component of anti-necrosis, and you know, our severe dry eye patients develop persistent epithelial defects and scarring, and you know, this potentially could be a therapy that we really don't have and may fit in very, very well with severe dry eye.
No, I totally agree. And actually, in fact, if we compare ourselves with dermatology or rheumatology, like Ophtha is advanced, but in biologic, we are not that advanced. So I think we will have a biological era in cornea and dry eye.
One more question. You know, when we use biologics in our, uveitic patients, sometimes they can get autoantibodies. Have you experienced any of that in the research?
So we did all the talks. We measured it. We didn't see anything which is concerning, actually. Yeah.
Great. Well, thank you.
Thank you.
Very interesting work. Our next speaker is Jeffrey Now from Oysterpoint.
Good afternoon. I want to thank the organizers for allowing Oysterpoint to speak today. Here are my forward-looking statements. I'm going to share with you 3 programs today, the first being our dry eye program with our cholinergic agonist nasal spray to treat dry eye disease. Our second is our proprietary enriched tear film gene therapy program. And the third is a bacteriophage program where we are looking to develop next generation antimicrobial therapy for the ocular surface. With our OCO1 varenicline nasal spray, this is a highly selective cholinergic agonist that binds to receptors on the trigeminal nerve to stimulate tear production through a novel route of administration by delivering it into the nasal cavity, bypassing the ocular surface to stimulate tear film production. Here are the primary endpoint data from the Onset 1 and Onset 2 clinical studies, as well as the integrated data. And what you'll see here is this is a study that's been run in a very wide population or broad population of patients. They could have eye dryness scores from 0 to 100 upon entry. We think this is very relevant to the patient population that will come through the clinic, and we're not really sub-selecting for the severe end of the spectrum. What you'll see here is in both Onset 1 and Onset 2, we had robust tear film production, as well as in the integrated data set to the right. This is the percentage of subjects gaining 10 millimeters or more on Schirmer score. With symptoms, on the Onset 1 study, you'll see there was directional improvement in both arms. In the Onset 2 study, similar with a dose response, and then in the integrated data set, you'll see on the right-hand side. I think this is really important data. Again, we're allowing patients with eye dryness scores across the entire spectrum into the study, and you'll see that improvement over control. From a safety perspective, you'll see that there are effects of the spray. Mainly 50% of sprays will involve the patient sneezing, no drug-related serious adverse events, and you'll see that patients' discontinuation from treatment was very low, with less than 3% in any of those treatment groups. Next, I'll talk about our enriched tear film gene therapy program. In our enriched tear film gene therapy program, we're delivering adeno-associated vectors to the lacrimal gland that will code for specific genes that may deliver peptides, proteins, and or enzymes into the acinar cells of the lacrimal gland. The goal here is, after transduction, for that particular gene product of interest to then be secreted into the tear film. Our very first program is delivering human nerve growth factor to the lacrimal gland. But what's also exciting about the program is we're able to stimulate lacrimal fluid production that contains the enriched tear film with the target of interest by delivering the cholinergic agonist nasal spray to the nasal cavity. So the patient can actually modulate the dose that's delivered to the ocular surface themselves by delivering a nasal spray through the nasal cavity. The last program that I'll talk to you about is our bacteriophage program. As we all know, there are a number of strains of bacteria present on the ocular surface that are commensal. There are also increases in bacteria that are resistant to current antibiotics. These are viral particles that are very specific and can be very targeted to go after very specific strains of bacteria. And then we're able to actually leave the commensal organisms on the ocular surface. And lastly, with our OCO1 and OCO2 nasal spray program, we have also been under a number of different research programs over the last year for SARS-CoV-2 and various variants. And what you'll see here is with both varenicline tartrate and simpinaclin citrate, the two molecules OCO1 and OCO2, we have very potent antiviral activity against a number of variants of SARS-CoV-2. We are currently studying this nasal spray approach to stopping transmission of the coronavirus in a number of different preclinical models. And then lastly, what you see here is we've just completed a study in rhesus macaques. You'll see on the top graphs the control arm and the bottom graph the treated arm. Left-hand side graphs, what you'll see is genomic RNA. So this is what we would get if we were to do nasal swabs in our normal testing paradigm. On the right-hand side, we see subgenomic RNA. And what we're able to see is that within a day or two after delivery of the nasal spray, there's no detectable subgenomic RNA in the nasal cavity. This means that the virus is not replicating and cannot be transmitted. Thank you.
Thank you. Oysterpoint's been busy the last time we've heard from you. Good work. Francis.
Yeah, congratulations, Jeff. This is a fantastic presentation, and really, as Ed has alluded to, really shows that you guys have been very innovative and really trying to be transformative in our ophthalmology space. The question I had was about the varenicline asset kind of lineup for the FDA approval. Obviously, when you're looking at a different type of molecule, a different type of avenue for approval, there's a lot of challenges, trying to get funding and trying to convince, people. As you get closer, and the study looks, phenomenal, and I can see this being a first-line, therapy, for example, for dry eye. Some of the areas that are a little bit more difficult for the clinicians are going to be the side effects, especially since we're really not used to prescribing, nasal sprays. So we don't really understand what the side effects would be typical for a nasal spray, what would not be typical for a nasal spray. How are you kind of trying to address some of those, or trying to allay some of our fears? It's great and comforting that the discontinuation rate was very low, but how are you going to go about trying to convince and really allay the fears that the side effect profile is kind of aligned with the other nasal sprays?
Sure. No, I think that's a great question. So obviously, in the field of ophthalmology, not a lot of nasal spray delivery. And so obviously this will be a new paradigm, although if you look across medicine, I think nowadays one of the, at least a few of the leading candidates on the migraine treatment side are also nasal sprays. Pain management is moving in that direction. I think for all of the clinicians in the room, you learned about the connection between the eye and the nose in school, so this pathway makes sense. From a safety profile perspective, patients are very comfortable with nasal sprays, so our market research has had really some great data. If you go to your local pharmacy, there's no lack of nasal sprays in the pharmacy aisle for things like allergic rhinitis and seasonal allergies. So we think it'll be very well accepted. And we often talk throughout the years about how patients have trouble delivering eye drops to the ocular surface. And we think this is another way in which many patients who are unable to deliver therapy or can't accurately deliver therapy to themselves would be able to do so.
Just a brief comment, describe maybe that the lacrimal gland delivery system, which is really, again, novel and transforming, the clinicians would inject the lacrimal gland one time, and you think comprehensive ophthalmologists would do that?
Yeah, so the way that the platform works is it's a injection into the lacrimal gland. It's transconjunctival, so the lid is retracted, and you can proptose the gland and pretty easily inject the lacrimal gland. People inject the lacrimal gland with Botox today for a number of different indications. And you could either inject one side or the other. It's a one-time injection. The adeno-associated virus will then transduce the ACE in our cells. They turn over very slowly. In fact, we don't know how often they would turn over, so this could potentially be lifelong production of the gene target. But what's really exciting about the program is that we can keep the level in the tear film at slightly above basal levels where drug is being put onto the ocular surface all the time, rather than this seesaw effect that we get with topical delivery. But then if we need to modulate it, so let's say, for instance, in the NGF program, if we have herpetic keratitis, after an infection, we can actually give the nasal spray to increase nerve growth factor in the tear film.
Great, fascinating work. Thank you, Jeff.
Thank you.
We'll move on. Next presenter is Carl Spana from Palatin.
Hi, good afternoon. I'd like to thank everybody, the organizers, for giving me the opportunity to introduce you to Palatin Technologies. We're a little bit different. We're kind of a new entrant into the ophthalmology space. So I think for most of you, this will be a first introduction, and it's really a first time that I'm speaking in front of this type of audience. So I apologize for any of the mistakes that I'll make and the fact that I probably have way too many slides. So we're a publicly traded company. We'll skip that. So what we are as a company is we're focused on the development of agents or novel agents that affect the melanocortin system. In fact, we're one of the first to get a melanocortin product approved. And what we're really interested in that system is its role in the resolution of inflammation and the ability to help tissues heal. And we think that this mechanism, we know that alpha-MSH, which is the endogenous ligand, is probably one of the agents that's responsible for ocular immune privilege, and we think that this mechanism will play a key role in both the front of the eye as well as the back of the eye. We have programs adjusting to both, as you can see on the slide here. This is a more mixed portfolio, but it's the second three that are of interest to this audience, the first being dry eye disease, where we completed a phase 2 study and are preparing for our first phase 3. We also think that the mechanism plays a very key role in corneal endothelial cell health, and so we'll be looking at other indications in the front of the eye later in this year as well. And then in the back of the eye, I want to take a second, although it's not the point of this presentation, but I think it highlights in the animal model some of the mechanistic things that we couldn't do in the front of the eye. And in the back of the eye, we know that this mechanism actually shuts down things like TNF-alpha, shuts down VEGF production, shuts down fibrosis, and it promotes IL-10, which is a pro-resolution cytokine. So it gives us an idea of what this mechanism can potentially do. So not only will it shut down inflammation, but it really will shut down fibrosis as well and provide an environment moving from inflammation towards resolution and more healing of the surface of the eye or the tissue that you're targeting. So just, how does this work? Mechanistically, this is really very cell-based. So what you're really doing in the resolution part is you're taking cells that are in a pro-inflammatory condition, and as they interact with the ligand, they're moving to a more regulatory or resolution state, and you're shutting down the inflammation. So you will see a relatively broad shutdown of pro-inflammatory cytokines and an upregulation of cytokines that are involved in the resolution of inflammation and tissue healing. So moving on to dry eye, we can skip that. So the first study that we did, and as a matter of fact, this is probably the first study for this mechanism in a large randomized controlled study in an inflammatory-based condition, was in dry eye disease, all comers, so mild, moderate, and severe. We did relatively little pre-screening. I'm sure you're very familiar with these types of designs. It was really vehicle versus active, which was essentially microgram of peptide in vehicle. Treatment was with a 2-week run-in and a 12-week treatment period. So the goal of the study was could we define a patient population, endpoints, signs, and symptoms that could be carried forward into larger studies and potentially registration studies. What patient population did it work best in? Very typically for a first attempt, particularly for those companies that are not experienced in the ophthalmology space, we didn't get it right. We didn't necessarily, there's a sign and symptoms where the co-primaries, ocular discomfort and inferior corneal fluorescein staining. We didn't see it in the general population, but as we move to the more moderate to severe population, we have a very pronounced effect on both signs and symptoms. In fact, we have very nice effects on corneal staining both throughout the various parts of the cornea. In addition, we saw very nice effects on shutting down inflammation, or at least as evidenced by lissamine green staining in the conjunctiva, starting as early as 2 weeks. So the symptoms, not quite as strong, so at 2 weeks, not quite through to the end. But what I would say, because my time's up, I'll give you a brief summary as we go through the summary slides. I said I had too many in here. We have a product that brings a novel mechanism that's involved in the resolution of inflammation and promoting tissue healing into the ocular space, broad-based both front and back. In the dry eye space, we have a product that was very well tolerated, no AEs, no dropouts due to the installation of the drug. It's very similar to taking an artificial tear. We saw pretty broad-based evidence in both the cornea, the conjunctiva, tear film breakup time, all showing very nice positive effects in the moderate to severe patient population. We've met with the FDA, have had an end of phase 2 meeting. I think we have bring a very innovative design to a first phase 3 study that we intend to start later this year in the 4th quarter. Thank you.
Thank you. Bob?
First of all, Carl, thank you. Welcome to the ophthalmic space. It's always nice to see a new entrant,
Sure.
And especially with a diversified pipeline. Very exciting. So can you walk us through your plans for phase 3? You mentioned, you touched on it, but maybe a little bit more details.
Sure. Part of the issues I see from dry eye was highlighted earlier. You have signs and symptoms that separate. You know, we see them in the same. You have a highly variable patient population. They may have gland disease, may have other causes. So we looked at it in 3 parts, which is 1, patient selection, making sure you get the right patient. 2 is, what are your right endpoints? This is only going into a second study for us, and it's a new area for us. So what we did there is we selected 3 primary endpoints, 2 signs and symptoms. We split the alpha. So if we hit any of those 3, not at 0.05, but at 0.0165, it's a successful study. We then also selected 3 secondary endpoints, key secondary endpoints, which again we'll look at simultaneously splitting the alpha there. So that allows you to essentially look at multiple endpoints. Yes, you take a hit, but I think in a product like this, if you're going to hit only 0.049, I don't think it really matters. You really should hit it pretty well. And then the third thing we did is we built in an interim assessment that allows us, with an independent committee that will look, and if you need more patients, you can go up. So we'll target 240. If you need more, you can put another 200 into the study, up to another 200, and that will be based purely on what they
So ultimately, that's your plan to manage your risk?
It's a way of managing risk in a highly risky...
Extremely risky.
Yeah. Again, we're bringing, this is new for us, so we're trying to bring it, we looked at it a little bit differently than maybe the community has looked at it in the past, and looking at adaptive designs and other ways. And the FDA was, I have to say, was quite accepting of these types of approaches.
Got it. Well, it was also interesting, your pipeline beyond dry eye. Maybe just quickly touch on that.
Sure. Again, in the anterior segment, there's a work that we've done, which we haven't published, but work that's done by the Residana group that really speaks to the role of this mechanism in supporting corneal endothelial cell health. So we're going through now, and hopefully we'll get invited to talk to you in November, and we can tell you a little more about what we're doing there. But you can think about things like corneal transplant surgery, cataract surgery, or any indication where the health of the corneal endothelial cell is important for maintaining a positive outcome or the health of the surface of the eye. And this mechanism may play a very key role. So we're very interested in getting those studies started.
Appreciate it. We have to move on. Interesting work. Next speaker is Kamran Hosseini. From Surface.
Hello, thanks for having me. Surface ophthalmics. I'm going to present 2 dry eye programs and 1 post-ocular pain and inflammation program. And I'm going to tell you what it is and why it's different. After all, there are 55 plus dry eye programs out there, so why is this one different? That's our leadership team. Our chairman is Dick Lindstrom. That's our medical advisory board. Ed Holland is our chair, and Priya Gupta is our chief medical advisor. So we are approaching this with a cocktail version. We have 3 building blocks. One is a corticosteroid that is new for US. It's been used in Europe, Asia, and Middle East, but never in US, and we are formulating the highest concentration globally. It's potent and it's safe. We are also using an immunosuppressant. We like it because it not only inhibits T cells, but also inhibits B cells, and we think it matters for the cascade of inflammation for dry eye. We like it because it also upregulates mucin production, which is an integral part of the tear film. And it is a safe immunosuppressant for over 5-6 decades now. And last but not least, we are also using a vehicle called Clarity, which was invented by Dr. Lindstrom. And its main function is addressing pain, it brings comfort, and it rehabilitates the ocular surface. So we put these three together in different concentrations and different formats and apply that in our therapies. So there is a lot of evidence just for ophthalmology for these building blocks, hundreds and thousands of them going all the way 40, 50 years ago. So the first program, and I'm going to tell you per each program why it's different than everything else that you've heard about. So the first program is SURF 100 for chronic dry eye. 3 different components are in there with 3 different concentrations, and it results into 5 different arms or different combinations and different concentrations. And we are running it, of course, against the vehicle. But why should you care about that? Because after all, everybody's running it against vehicle. And even if it's better than the vehicle, you still don't know whether it's going to be better than what you already have available out there. It's only a regulatory success in my view. So to address that, we are actually running it head-to-head against both Xiidra and Restasis. So 7 arms in this study. And what we are looking at is symptom. That's our primary endpoint. And we are looking at the number of signs, because after all, a patient never went to a doctor because they were complaining about their Schirmer score or Teer-Bellecopp score. It was about the symptom. That's why they would go to the doctor. So that's our primary endpoint. That study is actually 2/3 already enrolled. Next program is for acute dry eye. It's a dose-ranging study for betamethasone and Clarity vehicle. What is different about this study is that it's an 8-day dosing study for acute dry eye. But after the end of the dosing, we follow these patients for another 2 months because we would like to know how long is the runway. Actually, it's not us that really likes to know that, it's the payer and the FDA that would like to know that. Because after all, if after 1 prescription, you can be good and comfortable for another month or 2, then that means that you probably don't need to be on a dry eye medication day in, day out for the rest of the year. That program is also ongoing. We expect to have for both of them top-line results in the first and maybe second quarter of next year. Our last program is SURF 201, and that's for pain and inflammation post-cataract surgery. This one is already completed. I'm going to tell you what's different about this design, but before doing that, I'm going to show you some results. So let's take a look at the result for inflammation. All the way to the left, you see that big blue bar. That's the percentage of patients that were inflammation-free after 2 weeks of dosing. Right next to that, you see our vehicle. It's really not doing great. It's doing what every vehicle does it for cataract surgery, around 20%. I'm going to come back to this, why this matters, that this doesn't really work for inflammation. And then let's compare that to your beloved corticosteroids out there. Durezol, 41%, QID, ours is BID, and Lodemax, 48%, and there's another BID product out there at 26%. So that's for inflammation. Now let's take a look at the pain part. Again, our drug, 90% pain-free after 2 weeks of dosing. But let's take a look at our vehicle, 83%. The same vehicle that was doing nothing for inflammation or nothing extraordinary for inflammation. It is doing exactly what it was designed to do, address the comfort. It actually performs better than the corticosteroids out there. So, safety, IOP, everybody's worried about that with this potent corticosteroid. 0 patients had an increase of 10 millimeter of mercury after 2 weeks of dosing and exceeding the 22 mark. And what is different about this program, we are going to run it head-to-head against Durezol to seek superiority in the label, and we have agreed that already with FDA. So that program will commence in 2022. So what we learned here is that 2 of our building blocks are already working great. In fact, we had the p-value, significant p-value at day 8. And now the question is, the program SORP 100, will the synergistic effect that people have reported in transplant medicine, when you put mycophenolate next to a corticosteroid, and then you need a lot less corticosteroid, in fact, they call it corticosteroid-sparing strategy. Will it work for dry eye? So the results will come out, and again, the results will be compared to both performance of Xiidra and Restasis. And this is a 90-day dosing study. Our program is going to be a 2 weeks or a 4 weeks therapy. The reason we had to do it 90 days is to give Xiidra and Restasis a chance to show their effect. So in summary, we are 3 years old. We raised $44 million. We just announced the second round yesterday. 5 patents, 3 INDs filed, 3 clinical trials, 1 completed, 2 ongoing, all in a pandemic year, and we still have more than 50% of our cash in the bank. In fact, everything was done for the price of $16 million, IPO in 2022, and every program we are pursuing is in search of superiority in the label. Thank you.
Great, thank you.
Wonderful.
Marjan?
Thank you so much. So this is very exciting because you have sort of a triple threat. You have the immunosuppressant plus the steroid and the lubricant with the Clarity delivery system. This may actually have a very profound effect on a lot of other ocular surface diseases, including, autoimmune things, Stevens-Johnson syndrome, graft versus host disease, those very, very severe ones where you need that rapid and profound B-cell, T-cell inhibition and so on. My question to you is, have you thought of getting a broader indication for this, including things maybe like ocular allergy? And the reason I say that is because, unfortunately, payers will often make you fail or make the patient fail multiple trials before they allow, the next thing and potentially the next better thing. But if you get a broader indication for something that's a little bit more of a niche, whether it's post-transplant immunosuppression, post-corneal transplant immunosuppression, or autoimmune-related ocular surface disease, then perhaps it will be easier to access. What are your thoughts on that?
So yes, we have been thinking about that a little bit, and we are looking forward to more advice in that regard from people such as yourself. On earlier panels, people told us that in order to convince either payers or FDA that you do matter and why should they pay for it, come up with the data. And that's exactly what we are doing. We are running it head-to-head against what you have available out there. If our drug doesn't deserve to be developed, is no better, why bother?
Great. I applaud you for that, big clinical trial. I think it's like we said, it's what we want to see. So thank you. We'll move on to our last talk, Aziz Mottiwala from Tarsus.
Great, thanks Ed, and thanks to the panel and the organizers for having us. We all know we're in Vegas, right? And what happens in Vegas stays in Vegas. But if you have Demodex mites living and breeding in your eyelash follicles, guess what? What happens there doesn't stay there. It actually causes inflammation, irritation, loss of lashes, redness, can affect your vision. That's why we're developing the first drug to help these patients, to clear the signs of Demodex blepharitis by killing those pesky mites. We're public, so you know the drill here. And we've been very busy. We are working on an opportunity that is quite significant. Some of you may be thinking, I don't have mites. The person sitting next to me doesn't have mites, but guess what? There's 25 million Americans that have Demodex mites and Demodex blepharitis. In fact, if you're a clinician, more than half of the patients coming into your practice have Demodex blepharitis. You just might not have seen it yet, but you will. We completed our first pivotal study, the Saturn I study, where we hit all the primary and secondary endpoints and demonstrated complete resolution of the signs of Demodex blepharitis. With those results, we're encouraged and moved into Saturn II, which is underway. We'll have top line in Q1 of 22, followed by an NDA submission. We're advancing our understanding of the marketplace, looking at establishing a global footprint. We've already done so with a partnership in China, and we have a really exciting pipeline that is focused on empowering patients against their parasites in eye care and beyond. This is the Titan study. This is actually going to be presented in full later this weekend. This is the study that demonstrated how common Demodex blepharitis is in the practice. Over 1,000 patients presenting in multiple clinics around the country. and 58% of them had collarettes. There's about 45 million patients that visit the eye doctor every year, so that's 25 million Americans that are suffering. And these are patients that are your most common patients in the practice. Patients that have been diagnosed with blepharitis, guess what? More than 2/3 of them actually have Demodex as the root cause. Your dry eye patients, that's why we're on this panel, many of them have collarettes, telling us that Demodex is either concomitantly exacerbating the disease or may actually be the root cause of their discomfort. And we think about our cataract and contact lens patients who want to improve their vision, they're also a target patient to think about. So our solution is lotilaner. It's a potent GABA chloride inhibitor that's targeted to the parasite. We formulated this in a twice-a-day drop. Patients are used to taking drops. It's a very easy and elegant solution to fix this problem. You'll see how well this works right here. It actually, and we're very far after lunch, so if you see the bugs, it won't make people too squeamish here, but you see the drop penetrates in the lash follicles, paralyzes the mites, and as the mites are dead, we see clearance. And we saw this very clearly in our phase 3 study, Saturn 1, where we had all the endpoints. And we looked across 3 efficacy dimensions: collarettes, the pathognomonic sign of infestation, mites, and redness. And we also looked at safety for the drug. And it's very well tolerated. We had no treatment-related discontinuations. So I'll touch on each endpoint very quickly. For collarettes, patients started at grade 3, meaning they had about 100 collarettes on their lid. And at the end of 6 weeks, 81% of patients got to a grade 0 or 1, meaning they had a 90% reduction. Essentially, for the clinician, this would be clearance. With mite eradication, patients started with about 3 mites per lash. Again, you've got about 100 lashes with collarettes. You've got 4 lids. You've got over 1,000 mites on these patients' eyes. And at the end of 6 weeks, 68% of these patients had 0 mites. So we are getting to the root cause here. And redness, this was really encouraging. When we saw this result, we got really excited, and we've heard from a lot of advisors, some here on the panel, that this is really meaningful. 19% of patients got to a grade 0, meaning their lid was back to normal. 45% of patients improved at least 1 grade, and you can see from the visuals how significant that is. And this is something you don't see in ophthalmic drops. Maybe with a steroid, but with 6 weeks of treatment, eliminating the mites, clearing the collarettes, you're seeing the impact you can have on one of the most significant endpoints for patients and physicians. The drop was very well tolerated. As you'd expect in any kind of ocular surface patient, a little bit of burning and stinging with installation, less than 12%, no statistical difference versus vehicle. And in fact, the majority of patients said this was very comfortable, with 92% saying it was neutral to very comfortable. So we've got a lot going on. We've got our Saturn 2 phase 3 study reading out in Q1 of 22. We look to advance the pipeline, file the NDA in 22 as well, and read out our phase 1 study in Lyme and malaria next year as well. So lots of exciting things going on. We're in Vegas. I'll end with a Vegas quote, as the chairman, Frank Sinatra, said, "The best is yet to come." Thank you.
Thank you, Aziz. Nicole?
So Aziz and Tarsus, I just want to congratulate you on meeting an unmet need with this product. And so many patients that I see in my clinic that are referred in with a papillofollicular conjunctivitis, they've been on every medicine, and you just have them look down and you see the collarettes. And some of my own patients, I've missed it, that I'm going too fast and I don't pay attention. We have therapies like Clearadex or tea tree oil. They use it, they don't use it, it stings like hell. How long do you have to be treated? You said 6 weeks, but then how long does it last to keep the mites away?
Yeah, it's a great question. So we looked in our phase 2 studies, we followed a cohort of patients out for 12 months. And what we saw is post-treatment, the effect lasts for about 6 months. And around 6 months, the mites start to come back. And shortly thereafter, you see the collarettes and the other signs of disease. So we estimate, an average patient would probably take 1 to 2 treatment cycles per year, which is actually really patient-friendly. It's not having to take something every day for the rest of your life, right? It's 6 weeks, twice a year at most.
Great.
That's great.
Well, we're out of our time. I'd like to thank all our speakers and thank the panel. And I know I speak for the panel when we say that we're really excited about all these new products and potentially new therapies with new MOAs for treatment of dry and ocular surface disease. Thank you.
Thank you.